And if you can grab me some 3.0 monocryl and 3.0 nylon. So this is a dog with a cytologically confirmed soft tissue sarcoma. It's subcutaneous. The skin over the top is freely movable, as you can see there. There is this component here, which not quite sure whether it's fixed or not, so we're going to have a look at that. With the owner, we discussed the possibility of marginal resection versus wide resection, and reconstructing with the axillary flank fold flap, which would come down like that, or limb amputation, and the owner opted for marginal resection. Marginal resection, you can get a complete excision histologically in between 25 to 67% of cases. And if we get an incomplete excision, then reoccurrence rates are grade dependent, and 7% for a grade 1 and 34% for a grade 2. So regardless, we've still got a good chance of not having the tumour coming back if we're able to get it all out grossly. So I'm just kind of, I think I can get this skin back mostly together there. So I'm just going to come and do a incision along here. And when I'm doing this incision, I want to be really careful not to go too deeply and through the actual tumour capsule, because that's going to compromise the resection. And we'll get tumour cell contamination of the surgery site. I'm just going to come down through here where there's no tumour. I'm just going to undermine like this. And kind of do that in a stepwise fashion. Okay, so that's one side done. We're going to come and do the other side now. And once we've got the two skin incisions done, then we can then start working the skin off the lateral aspects of the soft tissue sarcoma. Again, just undermining. Making sure the skin's coming away nicely from the underlying tissue, including the tumour. If I'm worried that the skin is adhered to the tumour, then I'm going to readjust my incision to make sure that we're not compromising our resection. Okay, so that's the subcute, the skin incision. Now I'm just going to work laterally. I will grab the ligature if I could. So I'm just going to use the ligature just to have better hemostasis. I'm trying to stay as lateral as possible. So we can see the muscle here, and it's actually going underneath the muscle, which is a bit of a worry. It's all about trying tissue planes, and we're doing okay from the distal aspect of the mass right now. That deep tissue plane is coming out quite nicely. I'm more worried about the more proximal or dorsal aspect of the mass. So mostly through the deep aspect here. Tumor capsule hasn't been compromised, which is great. Okay, so this looks like it's going to come out nicely. So this is where a vessel sealing device really comes in handy as we're coming through this muscle here. Just gives you much better visualization and control of bleeding. So there's a mass. You can see it's kind of well circumscribed. It's not invased deeply. So hopefully this will come out as low grade and completely excised. And as you can see here, we'll be able to get a primary closure. So by getting a primary closure, we get significantly reduced risk of complications. And that's basically a lot of what this discussion comes down to. It's a discussion for the owners about whether they're more concerned about local tumour reoccurrence, and if they are, then you go for a wider resection, or about the risk of complications post-op. And if they're more concerned about that, then a marginal resection is a perfectly good way to go. Oops. That one. So as you can see, it's coming together quite nicely. The skin's to go. Last one. Okay, so there's our marginal section completed with a primary closure, which, as we said, reduces the risk of complications after surgery. And then hopefully with this more marginal approach, we're still going to achieve something close to what we could have with a wider excision, despite the more conservative approach and with a reduced risk of complications. So that was the aim for the owners, what they wanted. So we should hopefully be able to get a good result. We'll see you for the next one.